Hello, Health Psych students. This is the intro lecture part 2. Let me pull up the PowerPoint and get this going. All right, so we have been talking about if we had a magic wand and we could change one health behavior at a time. And again, this is pre-COVID. It would be cigarette smoking, it would be sedentary lifestyle, it would be changing nutrition, which is actually a little more complex. And then from a harm reduction perspective, we would want to reduce cases of excessive alcohol intake that causes violence or accidents. So I want to move on and talk about a study. This is the nurses' health exam study. And what they have done is track these nurses through midlife up until where they get disease, until where they die. In this particular case, all of these nurses are women. I know that guys can be nurses too, but in this study, these are all women. And they found that the women who did not smoke, who exercised at least a half an hour a day, who had a healthy body weight and were not necessarily overweight or obese, ate healthfully. If they drank alcohol at all, they drank it in moderation. These women who followed this healthy lifestyle decreased their risk of coronary heart disease, #1 cause of death for women pre-COVID again, by 82%. So a huge decrease in their risk for coronary heart disease if they held a healthy lifestyle. And so what this means is that prevention works, that if individuals are following a healthy lifestyle, they can reduce their risk even for the leading cause of death. Now, the punchline here is what percentage of these nurses actually followed this total healthy lifestyle. And when we had students live on this recording, we had guesses anywhere from 20 to 50% because nurses are healthcare providers. But here's the punchline. Only 1% of the nurses in this nurses' health exam study, where they were just naturally tracking these nurses and their behavior and their disease and their death over time, only 1% of them followed that healthy lifestyle. So this point here is there are a lot of individuals who are deliberately trying to target the health behavior of the healthcare workers, which is part of the reason why I'm so glad to have so many of you pre-healthcare individuals in this class, for at least to try to impart on you the knowledge of how important healthy behavior is for your personal health. But then also, if you're a healthcare provider and you follow that healthy lifestyle, you are a lot more likely to counsel your patients in a healthy lifestyle, as opposed to healthcare providers who are engaging in unhealthy behavior, who none of us likes to be a hypocrite. None of us likes that cognitive dissonance. And so people who don't follow a healthy lifestyle behavior are a lot less likely to counsel their patients in that lifestyle. So it can be a domino effect. If we get healthcare providers engaging in healthy lifestyle, we know that those individuals are a lot more likely to be out there counseling a lot of their patients on a healthy lifestyle. Okay, so let's talk about the healthcare crisis that we've been experiencing in the United States, and all of this is pre-COVID. I can't imagining the healthcare crisis resolving itself during a pandemic. In fact, I think we're going to have all kinds of other issues. So this is all pre-coronavirus, but having medical bills that you cannot pay is the #1 reason why people would file for personal bankruptcy. And when you file for bankruptcy, it's this legal action that you take that releases you from some of your debt and some of the bills that you owe. But what ends up happening after a person goes through bankruptcy, they can no longer get any credit. So you couldn't get credit for a car loan, you couldn't get credit for a mortgage, it just ruins your credit forever. So that's the downside. So there's an upside of releasing debt, a downside of killing credit. We know in the United States there are large disparities, the haves and the have-nots, and the haves tend to be individuals who are white males, after that white females, after that minorities, and then we know that individuals who are low socioeconomic status, so not very high in education and poorer in terms of wealth, tend to be the have-nots and have a lot less access to insurance and a lot less access to healthcare. So in an attempt to remedy that, in the Obama administration, they passed the Patient Protection and Affordable Care Act. And the whole point of the act was, well, there are a bunch of different laws. It was one big federal law, but all these different individual laws within the big package law was to narrow the disparity gap. And so when we talk about narrowing the gap, the point was to get everybody in the United States insured. so that healthcare providers, hospitals, the consumers themselves, the people who need healthcare, that everybody could get the healthcare that they needed because they'd be insured. And then from a healthcare provider standpoint and a hospital standpoint, everybody could get paid like they deserve to get paid. And so that was the number one thing that was tended for this Obamacare. It got nicknamed Obamacare. And I want you to know that the Patient Protection and Affordable Care Act, there had been politicians working on that attempt to get not necessarily universal health care, but to get everybody insured for many different generations of our United States leaders. The Patient Protection Affordable Care Act was passed by Congress. It was signed and passed by Obama. And then after it was passed, let me go to the next slide here. So let's talk a little bit first before we talk about that, of how it got vetted and what was the issue with the Supreme Court. Let's talk a little bit about the healthcare industry. We spend 16.9% of our gross domestic product in the United States on our healthcare. But I want you to know that that doesn't sound like a really huge number, but if you take a look at inflation since the 1960s, healthcare has risen 3 times the rate of inflation. So it's not just that it's gotten more expensive, just like a gallon of milk and a thing of bread has gotten more expensive, which would be the inflation rate. It's been 3 times that. Just to give you an idea of how much it has increased down here, back in the 1980s, we were paying $1,000 per person in the US for their healthcare a year. By 2015, we were spending about $8,700 per person for their personal healthcare in that year. So you get an idea of like how much it has increased. What I think is most important, though, we're going to go over here and we're going to take a look at average spending in these industrialized countries. So I call them our sister countries. So Germany, Canada, France, England. There has been inflation and increase in their spending over the years, and this stopped at 2004, but I want you to take a look at what's been happening in the United States. We have accelerated and broken away from the pack in how much we have been spending in the US relative to our sister countries. Now, keep in mind, our sister countries have socialized medicine and universal health care. We do not. We have an insurance system. And again, we have the haves and the have-nots, but we have been spending way more than the norm for our sister industrialized countries. Now, I think about this kind of like a bottle of wine. If it's an expensive bottle of wine and it is absolutely fantastic wine, if you've got the money, it might be worth the expense compared to spending money on a real cheap bottle of wine that tastes like crap. So if we're spending this much more money, then you would hope, right, that we've got much better health care. But we're not, and that'll be the point of this slide. But let's go up here and let's take a look at what is going on up here. 50% of our healthcare is public healthcare. It is tax-based. At the federal level, it's Medicare, and Medicare is the healthcare for people 65 and older or people who have a registered disability. Medicaid, on the other hand, is at the state level. So it comes out of the state level tax base. And Medicaid pays for individuals who are declared below the poverty line. And keep in mind, the poverty line bounces around by states in the United States. It's not the same level of income. In North Carolina, it's around $14,000 a year of income is considered to be the poverty line. And most states in their Medicaid programs are much more apt to fund children under poverty and make sure that they are insured necessarily than they are to make sure that adults are insured. But between the state Medicaid and between the federal Medicare, we are at 50% of the tax base funding our healthcare system. So one way I think about that, compared again, back thinking about our sister countries that we just looked at a minute ago, they are fully socialized medicine, single payer, universal healthcare. Their tax base pays for their healthcare. There's no insurance companies. When people are sick, they go get their medical care. They don't have to pay for it. They've already paid for it in their tax base. Everybody has healthcare, okay? So in our situation, we're halfway socialized and halfway in what I would consider to be, and this is going to be interesting when we hear, politicians debating about this, we're halfway there, but we're sloppy about it. And we have a whole insurance industry in the middle. And if you've got an industry in the middle, in between the consumers and the providers, that insurance industry, in order to exist and to thrive, has to profit. So there's this money that is being profited in the middle, in between the consumer and the provider. In our sister countries, it goes directly. The providers deliver services to the consumers, the tax base pays for it, there's no insurance company in the middle. We are the only developed country in the world, other than South Africa, that does not have a universal healthcare system. So in some ways, we are not the norm. We are deviant from the norm when it comes to industrialized nations. But we're not. We're spending more money, but we're not healthier. We have a shorter lifespan, higher infant mortality than many of our developed nations. And then the World Health Organization, I think you all are familiar with that, ranks the 191 nations, and they have found that we are 37th in healthcare performance in the US, and we have ranked 72nd in overall health. Okay, so we're spending more money, but we're not healthier relative to these other countries. And so that kind of begs the question, why the expense? So let's take a look. One of the things is that we are enamored with our technology here in the US, and there's been a big boom in technology. I think about this whenever I pass one of the signs. There's a sign on the way down to Hickory on 321, and it's advertising a 3D ultrasound for pregnant women. And it makes me think about back in my day when I was pregnant with my boys. I had an ultrasound, and it was 2D, and it was in black and white, and they looked like little aliens, but you could see their skeleton. And it was kind of sweet, just like, oh, my baby. But nowadays you got these 3D, I don't know if they're in color and they're 3-dimensional and you see your baby dance, I don't know what, but the sign is advertising saying, come to our hospital because we have the best ultrasound. Don't go to that other hospital that's got that old-fashioned ultrasound. I don't know if they're any better necessarily, but that's just an example of that. We also have specialty training for our physicians, and it makes a lot of sense that physicians deserve to be paid well because they've gone undergrad, they've gone to med school, they've done their residency. In a lot of situations, they have done fellowships. They have invested a tremendous amount of intellectual capital, time, money into their careers. It would make sense that we have to pay these specialty doctors at higher rates than, say, we would pay the old-timey doctors that did everything, or even pay doctors in primary care. We also have a really interesting thing that has occurred amongst physicians where they've broken the specialties into body parts, and we'll talk a little bit more about that later. So the diagnostic imaging industry is now a $100 billion industry, and that was way back in 2004. So we are spending a lot of money on diagnostic imaging. And it's an interesting kind of phenomena where the legal liability issues and malpractice issues, what they're driving is doctors ordering a whole bunch of tests at once and getting the results back, as opposed to ordering the test that they think is going to be most useful, getting those results back, and then figuring out how to do additional testing after that, which would be much more cost effective and which would reduce all of the false negatives that come back from these different tests. Another thing that's happening is we are engaging in very costly treatments, and we're ignoring the cost effectiveness of our treatments. So as an example, when physicians prescribe medications, they've usually had pharmaceutical reps visit them in their offices and present to them the scientific data on the effectiveness of their medications. And we give them free samples that they can give out to patients. And if the patients like the drug, then they end up buying the drug with their insurance or out of pocket after that. But rarely do physicians know the cost of the drug. So let me tell you this story that happened to me. So I go and get allergy shots once a week because I'm allergic to the world. Apparently the indoors, the outdoors. I don't know how I got that way, but I am. So I go and I get my 2 shots once a week, and then I have to sit for 20 minutes in the waiting area because they just make sure you don't go into anaphylactic shock and die after your shots. So I'm sitting there one day, and I hear this woman come up to the nurses station, and she wants to relay information to the nurses and her doctor. And what she's trying to tell them is that the ENT doctor had prescribed a medication for her that cost $4,000. So she's talking to the nurses. She's like, do you realize that Dr. So-and-so prescribed this and it's $4,000? And the nurses are kind of like, And they're not necessarily volunteering, like, whoa, let me go share this information with the doctor. And the woman just kept complaining. And she just said, I want to know, did he know this? And if he didn't know this, or he did know this, is there anything that we can do to make this, to get me a different prescription that will help me, that I can afford, that I can actually take? And it was one of those like, $4,000 for a med. Good grief, no wonder. Another issue that we have in our population right now is we've got an aging population. We have baby boomers. And what happened with the baby boomers is we had World War II in history, and we had World War I and II. And then finally we were war free. And the soldiers returned back to our country, and families became very, very traditional at that point in time. So the women like Rosie the Riveter, all these women who are out in the factories and working in industry, many of them lost their jobs because now men returned from war and they took over those jobs. And then many, many women and married, and they had very traditional relationships and made lots and lots and lots and lots of babies, because there was this hopefulness that was going on in our culture at that point in time. And those baby boomers, that big bubble of a population, we have not seen that type of population growth in generations since the baby boomers. And the baby boomers are older, and they're on Medicare now, and they're politically very vocal and very active. And they demand to get what they feel like they're entitled to, what they paid into in their tax base, all of their careers. And so now we've got this big group of individuals absorbing a tremendous amount of costly healthcare. And then the tax base, that is my generation and your generation, there's not as many of us feeding into the tax base to take care of this big baby boomer bubble. So that's another added expense that we are dealing with. Another thing prior to Obamacare was that many insurance companies did not support financially preventative care. You had to be sick, you had to have a diagnostic code before your insurance would kick in and pay for anything. And so it did not cover prevention. Obamacare has required that insurance companies cover prevention, which is really good. And I am a big fan of prevention, because if you can prevent costs in the future and you can keep people nice and healthy and their well-being, quality of life good, hey, let's do it. If you've got effective prevention, and we know we do have effective prevention. Another big cost is pharmaceutical companies. Now, when I was younger, pharmaceuticals could advertise to doctors, and you have all these reps that come in and wearing nice clothes, and they have this briefcase full of their pills, and they have lunch, they bring lunch to the doctors and the nurses, and they tout their meds, and they used to just market to the healthcare providers. Legally now, pharmaceutical companies are permitted to market directly to consumers, and you all know this. If you've heard commercials for Purple Pill, which was Nexium for reflux, or aspirin, or just there's all kinds of medications that are being advertised out there directly to the consumers. And I hear healthcare providers, physicians, PAs, whatnot, complain at times that people come to them asking for a medication, which in some cases is exactly what the doctor or PA would have prescribed. But in some cases, it's not at all their diagnosis. It's not at all, even if they do have the diagnosis, it's not the appropriate pill for them. And they wrestle, the physicians and the consumers kind of wrestle, like, do I give this pill that's not appropriate for them just because they're asking for it? Or do I push back and try to counsel them? And then are they going to be displeased with me? That type of thing. Another big thing, now this is a class in a psychology department, is that over time, and again, remember, our public health and our insurance companies are not socialized. They are not tax-based. They don't necessarily communicate well with one another compared to like our sister countries where tax-based pays for everything. So we've been ignoring the behavioral and psychological influences over time, things like cigarette smoking, sedentary lifestyle, diet, alcohol, stress, mental illness. And then what we don't know necessarily is the expense of COVID. Another thing I want to talk about, we're going to have an entire lecture on diabetes later on in the semester, but I want to talk about this trajectory that is occurring because diabetes is expensive, and I want us to look at the trajectory because this is going to keep adding to the cost in U.S. healthcare. So by 2011, only 9% of people in the United States had type 2 diabetes, but by But we project that by 2050, 1/3 of people in the US are going to have type 2 diabetes. And so we are seeing quite the escalation of people who have this disease. And we also know that having diabetes right now is a risk of death if individuals contract coronavirus. So we don't necessarily know what the prevalence of that is and how this is going to affect that projection. It's way too early to tell that type of information. But I want us to kind of take a look at how expensive diabetes is. So anchored at an average age of 50, an individual with diabetes in our nation pays $13,581 per year. If you compare that to an individual who is anchored at 50 again, that doesn't have diabetes, their spending is about $4,000 a year. So this discrepancy here in how much more we are paying and then what is supposed to be happening between 9% and 33%, we're going to see lots and lots more spending for people in US healthcare as a result of diabetes. All right, I want to talk a little bit about what's going on in healthcare provider shortage. We've had a physician shortage for quite a while right now. And one of the ways that our culture has dealt with the physician shortage is there has been development of physician's assistant programs, and many of you are pre-PA in this class. And that is typically a 2-year program, around the year, 2-year program. And then the PAs, once they finish their training and get licensed, they are supervised by a medical doctor. So a medical doctor or a DO, MD or a DO, has to supervise a PA. Another way that we have changed and provided more healthcare providers is in the past, nurse practitioners had a master's degree, usually FNP, family nurse practitioners. And now, even in North Carolina, our different universities have taken the FNP up to the DNP, the Doctorate of Nursing Practice. And the DNPs, those doctoral nurses, they can do everything that a physician can do except for certain procedures, and they cannot do surgeries. But they can do their own diagnosing, they can do their own prescribing, they can do certain simple procedures like install an IUD for a woman with birth control. And they do not need the supervision by a medical doctor. And so they are free to practice independently, which is a beautiful thing. And so they have added, the PAs and the DNPs have added a lot to primary care providers since there's a physician shortage in our nation. It'll be really interesting to see what happens after this pandemic. Are there some individuals who are really drawn in compassion, drawn to become healthcare providers because they know there's so many people suffering, they really want to help? Or how many people with intellectual gifts and intellectual capacity who could have gone into healthcare are scared, and they don't want to be on the front lines with a pandemic. They're scared, and it doesn't seem to pay as well relative to other types of occupations and career paths. And will there be less individuals trying to go into healthcare? So it's going to be interesting to see how this pans out. I can tell you that there's a shortage of clinical psychologists all over the nation, but especially in rural areas. So as an example, we have psychologists in Watauga County, Boone, because we have the university and because we have the counseling center, and then because we have, in a lot of cases, they are partners or spouses of those people who are doing private practice in the community. Like I do a one afternoon private practice in the community myself. But we get out into neighboring counties, and we get rural. You go from Watauga County and you start getting out into Avery and Ashe and Allegheny, and we get rural very, very fast. And the whole socioeconomic status situation changes very, very fast. And we've got neighboring counties that have 0 psychologists in the counties. We've got a couple of our faculty members, Dr. Kurt Michael, Dr. J.P. Janison. They are in 3 neighboring counties in the ASK centers. So they serve the students in the public schools. And then we've got doctoral students that go and train in the ASK centers. And in many cases, the ASU involvement in those schools is the only psychology services in those rural counties. So there's a big shortage. It's part of the reason why ASU, we have developed, and we're very proud of our program. It took us about 10 years to plan it and go through all the politics throughout the UNC system to get the doctoral program, because ASU is not supposed to have doctoral programs. We are a comprehensive university. We finally got it approved. We have our second cohort coming on board fall of 2020. And we are working very hard for APA accreditation. So it's part of trying to train individuals who can get licensed and practice in rural areas and do psychological testing, psychological diagnosing, psychotherapy, behavioral interventions, whether it be in a medical setting, in a school setting, in private practice, on a mental health clinic. These PsyDs are meant to be generalists and serve the needs of rural communities. Okay. All right, let's talk a little bit about the Patient Protection and Affordable Care Act. This is the true name of this big federal legislation that had all these individual laws in it. It got nicknamed Obamacare because it happened and it was facilitated by the Obama administration. In some ways, the nickname Obamacare has fared it well. In a lot of ways, particularly during the Trump administration, the term Obamacare has fared very poorly because it's associated with a previous president. And there are even, I found it interesting, how there are individuals who got their insurance in the insurance exchange. So they got the new insurance, but they had no idea it was because of Obamacare. And if they did, they would be like, I don't want that assistance. So you all know some of these, and keep in mind, this law went into effect in phases across the years, allowing the nation and the states to adapt to certain types of legally required goals of Obamacare over time. So this is what happened first. And this benefits probably many of you in the class. I know it benefited my sons, where children can stay on insurance until the age of 26, until they can get their education or get their skill sets and launch in a vocation or whatnot. Whereas previously, when you were 18, you were kicked off of your parents' insurance. And I know when I was in college, every semester, my parents' insurance company, as long as I had to prove to them, I'd have to go to the registrar and I had to get the certification and prove to them that I was indeed in college and passing, and show that to my insurance company every year in order to stay on my parents' insurance until I graduated college, and then I was kicked off. They also, in the first phase of the Affordable Care Act, you could not deny people with pre-existing conditions health care. I've got a nephew who's been through several types of cancer, and it would be horrible if, because he had cancer when he was a child and was taken care of, which helped him survive, it would be terrible that if he became 26, kicked off his parents' insurance, and then could not get health insurance because he previously had cancer, which is horrible to think about. I mean, oftentimes those are the individuals that need the health insurance and the continued monitoring of their health over time. Another thing that Obamacare did is require prevention services. And I love this one because not only do we know scientifically that prevention services tend to keep people healthier and catch disease early and keep people from getting full-blown disease, it works, but also psychologists rolled in here. This is where we rolled into insurance that was required for individuals, where our services have to be paid for. And so this way we have been able, as well as like OT, PT, dietitians, that type of thing, this has allowed us in the healthcare system to integrate because insurance companies pays for everybody. And so that's allowed for that integrative care. I do want to talk about part of the reason why after the Affordable Care Act went through, it was passed by Congress, it was signed by our president, so it had been vetted as a federal law like you're supposed to vet. There were a lot of people out there that were complaining that the law was, even though it had passed, was unconstitutional. And the reason why it was considered to be unconstitutional is because if you were a citizen or had a family and your business or your employment assuming you're employed, didn't fund you with private insurance. You had to purchase through the Obama Exchange program an insurance plan for you and your family. And if you did not spend that money and purchase that insurance plan, then you would be charged a penalty. Okay. And that's the part that was considered to be unconstitutional, paying this penalty if you weren't insured. Now, I don't know if you all remember, because you're young, I don't know how familiar you are with your tax forms, but it used to be you did not report your insurance on your yearly tax form to the state or to the federal government. Now there is a place where you have to verify that you have health insurance on your tax forms, because that was where, if you did not have insurance, then the IRS would come back to you and ask you to pay that penalty. Now, I want us to think through this, because there's kind of two sides of looking at it. So this is where people thought it was unconstitutional. Like, okay, there's this penalty if you don't buy insurance. Now let's think about this with a car. I know for those of you who have a car and drive a car, are you allowed legally to drive a car without having insurance? The answer is no. In that argument, for the people who thought the penalty was unconstitutional, they would say, well, a car is a privilege and you don't have to have a car. But if you do have a car, you have to have insurance, at least the basic liability for your car. So this, because it was accused of being unconstitutional, went through the court systems. Not only had been vetted by Congress, it had been vetted by the president, and went all the way up to the Supreme Court. And I still remember the summer I was on vacation eating lunch in a restaurant, and there was a TV on, and the Supreme Court was about to make their decision. And because of the makeup of the Supreme Court at that time, I was pretty confident they were going to vote that baby down. And I just remember sitting there, I think it was Scalia was the swing vote. And I remember sitting there and hearing the news that the Supreme Court deemed this healthcare to be constitutional. So this, as a federal law, has been one of the most vetted laws in known history. It's gone through, the House, it's gone through the Senate, it went through the president, it's gone all the way up to the Supreme Court, and everybody says this is a great idea, okay? Moving us closer to universal health care. In 2019, though, because of some of the contention related to the penalty, the Trump administration canceled the penalty. So now if individuals do not opt in to the exchanges, they don't have to pay that penalty anymore. So a year later, these were some of the things that rolled into the plan. And I'm not going to go over these things here, but different ways that doctors are getting paid, trying to make sure that the healthcare plans were equitable across people, so that there still weren't healthcare plans that were creating haves and have-nots, of people have-nots being underinsured, that type of thing. And what they were really trying to do was, by 2020, and you've heard this term, elimination of the Medicare gap, or complete expansion is another term, meaning the goal was by 2020 to have every US citizen insured. Okay, that was the ultimate goal of let's try to close the gap and make sure that they're not uninsured people out there, which healthcare providers really wanted, because they wanted to know that if I see this person and I treat this person, am I going to get paid by? Are they going to have insurance so I can get paid? So we had this really interesting thing that happened, is that the federal government in this law gave an incentive to every state of the United States to join in this expansion to try to close the Medicaid gap. And the federal government, what they offered the states was to pay for all of their citizens to get health insurance 100% for 2 years after the law passed. But then, so the federal government would help out the states and get everybody in the state insured. But then the states would have to wean off the federal money, coming up with their own laws and their own tax base, so that over time, the states were taking care of their citizens' insurance, of people who didn't have private insurance, so that everybody was insured, with less reliance on the federal dollars over time. Now, this became very interesting how the states decided to either join this or reject this, fell directly on party lines with the exception of 2 states. So all of the states that had tended to vote Democratic and who had Democratic governors welcomed this expansion. They're like, yes, we will take your federal assistance. We will get everybody insured. We will figure out in our own tax base how to keep this going and sustainable over time. All of the US states that vote Republican who had Republican governors, minus 2 states, all of them said, no, thank you. I don't want federal dollars. I don't want big government in our business. We can take care of ourselves. Thank you very much. That type of thing. There were 2 governors. One was a female governor from Arizona. I can't recall her name. But 2 Republican governors really felt strongly that they wanted their citizens insured, and they fought hard against their party lines and were successful at letting their states join into the expansion and take the federal dollars and get their people insured. So it's interesting how political healthcare has been and how political healthcare is now. It is fascinating to me. So what did happen in North Carolina, we were one of the states that at the time we had a Republican governor, and we said, no, thank you. No, thank you. We don't want the federal assistance. We don't want to close the gap in North Carolina. But as a result of the federal law, we had many more North Carolinians signing up for healthcare. So we had a lot more people that just followed along and thought, okay, well, yeah, let me get this exchange there. You could get exchanges at different rates relative to your income. The majority of us who have insurance in North Carolina, we get it through our employment. So I have the state plan, which is through Blue Cross Blue Shield because I'm a faculty member at ASU. Here's the other kind of layout of how people get their insurance in North Carolina. We still have 11% of people in the U.S. in North Carolina that are uninsured because we didn't buy into this expansion. And just to kind of break that down and give you a little bit of a feel for it, in Watauga County alone, 4,000 people are uninsured. I donate a little bit every month to the community care clinic. The community care clinic is the clinic that it's a primary care, but they've got some specialty people that volunteer. Primary care clinic in Boone that serves only the uninsured. And keep in mind that our hospital system, Appalachian Regional Healthcare, helps supplement the funds that go to the community care clinic because it's in their best interest to keep people going to the community care clinic who are uninsured and getting primary care at the clinic as opposed to showing up at the Appalachian Regional Healthcare like Watauga or Cannon, showing up to their ER where they have to give them care in the ER that is very expensive care that in a lot of situations could have been treated in primary care and did not need an emergency department. So just to give you a feel for how many people are still falling through the cracks. Okay, so different ways that we have made attempts to contain costs in the healthcare system because we've already established that we're spending way too much money. It's not necessarily resulting in better healthcare. And so there is definitely waste in the system. And so one way of thinking about it is what can we do to clean up waste and make healthcare more efficient and ideally drive down costs? So let's talk about mental health parity laws. So once upon a time, when you had an insurance, assuming you had insurance, you had medical insurance and then you had mental health substance abuse insurance. And they were 2 very different, separate companies. They were not the same company. And what ended up happening over time is that medical insurance companies oftentimes had lower deductibles, lower premiums, that type of thing. But the deductibles or the out-of-pocket that you would have to pay for any mental health care could be very, very high at a ridiculous level that would actually disincentivize people for going to get substance abuse care or mental health care because it was way too expensive. I knew a gentleman that I treated after he was having issues after cardiac rehab and his medical bills had all been paid. He didn't have to pay anything out of pocket when he got any more medical care that year, but he had $1,000 deductible for his mental health care. And I can tell you The scientific literature suggests that most people who access a psychologist or a social worker or a counselor, $1,000 for a lot of individuals, the data suggests that they get the therapy they need, they terminate because they're feeling better well before $1,000 is spent. So it's kind of a ridiculous amount. So mental health parity, North Carolina was actually very progressive in passing mental health parity. Made insurance, if you had an insurance plan, they insisted that the medical deductible premium cost, all of that was covered, that mental health and substance abuse was covered in that premium, and that the co-pays had to be the same, that the total out of pocket that you had to pay until the insurance kicked in had to be the same. And what happened when that occurred is that these companies rolled in together. And so most companies now are overseeing not only the medical care, but the mental health and substance abuse care, which is a really good thing because that made the insurance companies integrate. Got it? They had to integrate. Okay. So now let me talk a little bit about Kaiser Permanente. Kaiser Permanente is a huge health maintenance organization, and it covers more people in California than any other insurance plan. It's a HMO. So what that means is if you have Kaiser Permanente, if your company, let's say you work for a company, and that's your insurance, it's KP insurance, then you have to go to a KP clinic anytime you need healthcare. You don't get to pick doctors outside of KP, that type of thing. You go to their primary care clinic, and everything, you might have a teeny tiny deductible or teeny tiny copay that you have to pay. But a lot of times it's free after you have the insurance, but you have to go to their clinic. Keep in mind that in their clinics and even in their hospitals, Kaiser Permanente salaries all their healthcare workers. So they're not doing private practice within the medical system. They are paid a set salary, and they work 40 hours a week, and they see their patients, and they do what they do in healthcare. So Kaiser Permanente had some really smart executives who took a look at all of these patients that were coming into their primary clinic, and what were they coming in there for? And what they learned when they started looking at the data was that almost 80% of the people showing up through their doors were there because of stress-related medical illness, or they were there because of stress-related psychological disorders. And so, meaning only 20% deserve the traditional care. Check in, see the nurse, get your blood pressure, all that kind of stuff, go see a medical doctor, get your prescription, and that kind of care. So if it was stress-related illness or psychological disorders, what Kaiser Permanente did is they switched the gatekeeper. So everybody walking through their clinic would sit down with the health psychologist for about a 15-minute interview. And that health psychologist would ask them about their symptoms and their reason for being there today. And then oftentimes ask them a lot more questions after that. And they were the gatekeeper to the traditional medical care. So as an example, let's say they have a young woman come in, and the health psychologist is like, how are you doing? The woman's like, I'm really struggling with a sore throat. And the woman says, my throat's on fire. My kid had strep last week. Are there any other things that you're here for other than your sore throat? And if the woman said no, then the psychologist would be, by all means, you go there and see the nurse, and she'll swab your throat and see what's going on. Okay. And then maybe you need to see the doctor, that kind of thing. But in other situations, like let's say they had somebody come in and said, I've had insomnia for weeks, and I'm just deteriorating because of my insomnia. A good psychologist is not going to be like, oh, go to the doctor and get meds for insomnia. They're going to ask a lot more questions about what's going on, what's driving the insomnia, because it's usually stress. It could be PTSD. They could have been traumatized. It could be classic depression. You tend to see insomnia and depression. And that health psychologist is going to ask all the right questions to rule in a diagnosis, and then refer that individual either to like a stress management group therapy, or let's say they've got PTSD because they've experienced a traumatic event, and have developed PTSD as a result of that. They might send them to an appointment with a psychologist, or see them themselves if that intake person has office openings. And what they found by switching the gatekeeper, having everybody talk to a psychologist before they access medical care, the patients liked it because they were getting the care that they needed. And in a lot of cases, the care that they didn't even know they need. So the person with insomnia who had PTSD might not even know, hey, wow, PTSD, and it's treatable with psychotherapy. So the patients liked it. Kaiser Permanente liked it because they ended up saving a lot of costs because they weren't having people who needed psychological services going and seeing the medical professionals. So it ended up being this win-win situations. The consumers and the customers on the insurance were happy. The administration of the company was happy. They were making more profits. So win-win-win. All right, let's talk about Jody Palaha. Jody Palaha, Dr. Palaha is my friend, and she is at ETSU, and she works in the pediatric section of the medical school as a pediatric psychologist. And she takes her doctoral students and her med students out to these remote healthcare sites, primary care sites in rural Tennessee, and they spend a day a week at a PEDS unit, a pediatric office. And what they end up doing is that, keep in mind, first of all, that at pediatricians' offices, you've got parents bringing kids with a variety of problems. So medical problems that the pediatrician should be treating, but a variety of problems that parents struggle with kids that are behavioral in nature. They are not medical in nature. So an example would be difficulty putting a child to get to bed and getting a child sleeping, which for a lot of parents, like kids might be sleeping really well and going to bed really well, and then they get sick. And then after they get sick, then it's hard to get them sleeping well again. And so they relapse and they have to go back. Potty training issues, issues with feeding at times for kids, issues nowadays with kids who are overfeeding, because we've got more kids developing type 2 diabetes, issues with like, do they have ADHD? Do they have a learning disability? Is there violence going on in the family and the family needs shelter, that type of thing. So all kinds of behavioral issues that families could be going through. So when Dr. Palaha and her students are on the PEDS unit, there's this thing that physicians do when they transfer patients over to another healthcare provider. It's called a warm handoff. And it would be something like pediatrician realizes that the mom's having issues with the kid sleeping. You know what? I don't want to prescribe that child sleep meds because we're going to create a whole host of other problems if I do. How about I walk you down the hall and we meet Dr. Palaha and you sit down and talk with her and her team. She is a pediatric psychologist and a professor at ETSU, and she and her doc students are really good at helping parents with sleep issues. You want to go meet her? Down the hall, shake hands. That's going to end, I think, in healthcare after this pandemic. Shake hands, give the warm handoff. Dr. Palaha sits down and her team, and that family is going to leave that office that day going, okay, well, now we know what we're going to do tonight and tomorrow night and what we're going to do to help this kid get back into a normal sleep schedule. What is interesting from a financial standpoint is that her team can bill psychological services, so that PEDS office is making more money off of their team when she's there in the PEDS office that day. The pediatricians, the medical doctors, they like it because they're not having to hear about and deal with these things that really aren't in their purview. It's more of a psychologist's purview to deal with the behavioral stuff. And they also like it because the pediatricians can see more of their patients and deliver more of their health care to their patients throughout the day. And then therefore they end up billing more dollars because they're able to see more patients. Psych is able to bill. The consumers, the parents, and the kids benefit from it. This is win-win-win, folks, okay? And I like looking for solutions that are at least win-win. So knowing how valuable integrative healthcare is, we know now that the American Academy of Family Physicians, which is the accrediting body for anybody who goes into family medicine and trains in med school, this body has adopted integrative medicine. So their med students and their residents, they have been training alongside psychologists, physical therapists, occupational therapists, dietitians. They've been training in integrative care all through their schooling. Okay. And so it's interesting. We've got a very different mindset from the younger medical doctors out there nowadays than the really older medical doctors that did not train in integrative care, did not get understanding of what these allied health professionals can do to help them with their patients. Because of that, because med school, at least in the family medicine programs, has integration, there has been a change in the MCATs, which is the test that individuals have to take and score high enough to be able to get into med school. The MCAT used to be all physical, natural sciences, and now the MCAT has the natural sciences in it, but it's got a lot more psychology and a lot more social science in the tests nowadays. Because that's relevant. Students need to have that knowledge base, which is why I'm so glad that I've got you all in this class, because many of you are going to be future healthcare providers and you need to understand what integrative healthcare is about. But then even backing up from that, if it's going to be on the MCAT and it's going to be more of a requirement, say, for PT programs, for OT programs, as well as like clinical psych programs, this has now fallen back into different universities and how we've designed our degrees. So as an example, in our psychology department, you can now major in psychology and go to med school or OT. I get a lot of advisees that are pre-OT and pre-PA and pre-med in my office because I advise the health studies concentration. But now we have a bachelor's in psychology, and you can concentrate in natural sciences or you can concentrate in health studies, which is perfect for these healthcare careers. For the people who want to go into social work, counseling, clinical psych, we have the BS in psychology with the human services concentration. So they can get all of the needs that they have to qualify them in training to be ready to train in these mental health services graduate programs. So again, the nice thing about integrative medicine is that most health professions have now embraced it, and it's trickled all the way back down, even into the curriculum in the bachelor's degrees, which is some of the reasons why some of you are taking this class. Okay, so here we're about to launch into talking about behavioral strategies or interventions. I just want to define this word here. When we do an intervention, we intervene and try to problem solve and help an individual. So penicillin would be an intervention if a person had strep throat. What we oftentimes do as psychologists is we do behavioral or psychological interventions to help individuals. And so now we're about to be talking about these behavioral strategies that are both targeting medical health and mental health. So they're targeting total mind body. Sometimes they have a medical diagnosis, but total mind body. And we're really trying to help the whole person. And wouldn't it be great, with all the financial woes that we've got in our healthcare system, wouldn't it be great if these save money, so they reduce costs, and wouldn't it be ideal if they improve quality of life for the people out there who are accessing healthcare? I think I've been trained a la Dr. Robert Kaplan, who is a big advocate in public health, community psych, clinical psych, and healthcare, that we use quality of life as an outcome measure for everything that we're testing, meds, behavioral interventions, everything, because isn't quality of life what it's all about? Here's my meaning of life, quality of life, is that when we have really high quality of life, we can do all the stuff we need to do. When we are happy and healthy, we can do everything. When we are sick, we're not doing as much stuff. Okay. When we are just sick and disabled, so imagine a person who is having fever and difficulty breathing because they have the virus, they're doing very limited stuff. I've had a friend who had a 7-week fever and 7-week fatigue and 7 weeks of difficulty breathing. She was not doing much stuff. And then when we're dead, at least here on earth, when we're dead, we're doing zero stuff. So quality of life kind of as a metric of our ability to do the things that we want and wish to do in life should be the outcome of any type of research. Okay, so now we're going to launch into, this is a relatively old article, and I want to own up to that, Friedman and all, back in 1995, but I continue to use this article because I love the way that they've put labeled on these 6 pathways. But what I want you to know is I'm going to go through and I'm going to define each of the 6 pathways, and I'm going to give you some example studies in each of the pathways to bring the pathway to life, to help you understand what the intervention, a possible intervention, could look like, as well as the financial outcome of that intervention as a means of cost saving. What I want you to know, though, is that this field of research of, a lot of times it's called cost offset research. If you do the behavioral interventions, how much cost offset do you save from unnecessary medical care? And then therefore, does the health insurance company or the hospital or the primary care save money? There is a whole body of research that has continued in all of these different pathways since 1995 up until now. So the date of the article is a bit outdated, but the names of these things and the research has continued. I just want to give you a flavor for them. Okay, so keep in mind that these interventions we're going to be talking about, psychologists could deliver them or allied healthcare professionals could deliver them. They all improve quality of life, ding. They all reduce costs, ding. And they do so by targeting demand for healthcare. So I want to spend a moment here talking about the economics of healthcare. Most cost reduction interventions up until this time have been reducing access to healthcare. So as an example, a disallowance of access would be like, let's say there's an older person who doesn't like their wrinkles and they want to go get Botox for their facial wrinkles. And they say, healthcare insurance, will you pay for this? And healthcare insurance universally would say, no, that's cosmetic. If you would like to go get Botox for your facial wrinkles, you may, but you get to pay for it yourself. That is not a medical problem. That is not a medical diagnosis. It's a normal part of aging. We're not going to pay for that. So that would be saying, no, you don't have access. Okay. The flip side of that would be targeting demand for healthcare, which would be the consumer going, I don't need to go to the doctor for that. I can either self-treat for that, or I will wait until I make sure that, I need to go to the doctor before I access that. Would be helping the consumer in ways that they don't need as much medical care by targeting the demand. Okay, so this was, I don't have clickers right now where we're online. But this would ask the question of how is everyday illness treated? And for most of us, we treat everyday illness by ourselves. So there's probably women in this class where once a month you get your menstrual period and you have menstrual cramps and it's crampy and it hurts and you take some kind of medication like Aleve or Motrin to help ease those cramps. That would be an example of self-treatment. Most women, we get wise with this stuff. Most women every month when they have menstrual cramps, they don't go running to their OBGYN, help me, I'm hurting. They figure out how to manage it with their own self-medication. A lot of people though, there's a lot more going on in this slide than the family cat joke. A lot of people, when they've got symptoms, they reach out to people around them and they ask, am I okay? Do I need to go to the doctor? Or at least feel for me because I'm feeling bad. I can tell you my sons, even when they were in college, when they would have a fever or if they would throw up, they would call their mom. When they were in college and they called me like, I've been throwing up. I'm like, were you drinking? No, I wasn't drinking. I don't feel good. I have a fever and I'm throwing up. And and they would just, there wasn't much I could do for them other than like, oh, I'm so sorry, sweetie. And have you done this? Have you done this? That type of thing. But the point being that a lot of times we reach out to others for information, trying to decide what should we do about this particular problem? Is it a minor issue? Is it something that's very serious and we need to do something pretty dramatic in terms of accessing healthcare, like going to an emergency department? Okay, so pathway number 1 is called information and decision support. And in this pathway, it just assumes that a lot of times people out there aren't making the correct decision about whether or not to access healthcare because they don't have the information. So basically they are ignorant, but I want to be careful when I use this term. When I say ignorant, I don't mean mean. I mean ignorant as in not having the information. And it's kind of this type of thing of like, how do you know what you don't know? You can't know what you don't know, okay? You can't know it until you know it, and then you can know it, that type of thing. And so if you provide people with the correct information, will they make better decisions? So the classic example here is that young parents, they have a baby, and I find it fascinating. Like, you don't have to take a licensure test. You don't have to take, a multiple choice test. You don't have to prove you're a good parent. Anybody can have a baby in a hospital, and if everybody's healthy, they discharge you and they send you out without a YouTube tutorial. There's no instruction booklet. Everybody just assumes they figure it out and know what they're doing in parenting the children. So young parents get very, very nervous when their kids have fevers. And there are a lot of parents who make it their norm. I've even had friends who've done this, that every single time a child had a fever, they would take them to the pediatricians. And then here's where it gets real expensive: if on weekends and evenings, take that child to the ER. I was not one of those parents because I understood fever. And here's what these individuals needed to understand: that first of all, fever is adaptive. It means a child has a pathogen, and that fever response raises the body temperature because at a higher heat, a lot of those pathogens naturally die. Parents need to know that babies can tolerate a higher fever. They need to know how to take the fever. And normally you do, nowadays you've got stuff for the forehead. In the old days, you had to put a thermometer up a child's rectum and get an internal temperature that way, because they're not very good at holding it in their mouth when they're babies. So knowing that children can tolerate the higher fever, how to take the fever, and then how to treat the fever with liquid Motrin that is at that appropriate dose for that baby's weight. And I can tell you from parenting, I know when my boys, when they were little and they would have a fever, you would be holding that little baby with that bottle with that Motrin, and just hold, as they were drinking it, you would feel that fever drop. So very effective fever management using that Motrin for babies. So in this one particular study, what they did is they gave half of young parents this information, and the other half, they did not give them that information. And what they found is that those that did not have the information accessed their pediatrician much more frequently than they needed to. And those who had the information self-treated fever at home, and they did not access unnecessary health care. So I'll tell you a quick story. When my son Forrest was little, I think he was about 3 years old, something like that, he had been coughing a bit. And I remember one morning I was, getting ready for everybody's day, and my mom called me because we had some family business we had to take care of. And we deal with the family business really quickly on the phone. And she just says real quickly, "How's everybody doing?" And I just said, "Oh, I don't think Forrest is feeling very well." So she's like, "Put him on the phone." So Forrest, gets on the phone with his Nana, and she's asking him how he's feeling. And he said, his symptom, he says, "My heart hurts," because he'd been coughing. So his chest was a little sore. So his heart was fine. "My heart hurts." And I hear my mom go, "Put your mom back on the phone." So, here I get the phone. She's like, "You've got to get him into the pediatrician's office." I'm like, "I know, I do. And I hang up, and it was one of those things I'm feeling guilty as a mom. Like, why wasn't I thinking about this beforehand? Oh my gosh. And I rearrange my schedule, and I get him in, I take him in that day, and they examine him, and they're like, "This looks viral. His temperature's not that bad. He's running around being the crazy self, and he was eating like he normally had all this energy, and he still had it." And their advice to me was, "There's really nothing we can do. If he develops a low-grade fever and this keeps continuing, in a couple of days, come back in, he might need an antibiotic." So it's one of those things where it was like, why did I make that decision? And I made that decision because of that phone call, that family phone call that day. Another example of intervention here, this is an insurance company that gave out to half of their customers a telephone line that they could call 24/7, and the other half of the people in their insurance company customers, they got nothing special. So everybody's getting medical care as needed. And with the phone call, you could call in 24/7 and talk to a nurse. And the nurse had in front of her a bunch of algorithms. So you would call in with whatever symptoms, and he flip through the algorithm and either help coach you on how to self-treat, or tell you that you needed to make a doctor's appointment, or tell you that you needed emergency care. So as an example, you call up and say, "I've got this burn from the stove," and then that nurse might talk you through how to clean and bandage that burn, and you probably don't need any medical care after that, or maybe you need to take some Motrin if it's hurting, that type of thing. Other examples: elderly woman calls in, says, "My husband's complaining of leg pain. It was down at his ankle, now it's up at his knee." Nurse asks, "Does your husband have a history of cardiovascular disease?" "Yes, he had a heart attack last year." Hang up and dial 911 immediately. So in some situations, helping people self-treat; in other situations, helping people know when they needed to access healthcare and if they needed emergency care, like that last example. And wouldn't that be nice to just, nowadays, you know what happens is people Google and sometimes they get really good information from the internet, and sometimes they get very complicated or misleading information from the internet. So wouldn't it be nice just to be able to call up a healthcare professional and counsel them? Okay, I want to talk about the financial results of this. So for this insurance company, for every $1 they paid per person, they saved $2.50 per person. And so I want you to get into your notes. This discrepancy here, this is called return on investment, oftentimes in business world, ROI. That is a very good return on investment. To donate $1 and get $2.50 back, you have made a nice cost savings there. So you can sort of see in this particular pathway how valuable that was for people. Pathway number 2, the psychophysiological pathway. So here we see the psychology and here we see the physiology. And I'm not going to spend much time on this today because we're going to spend a whole big lecture on stress and coping. But this is basically stress, particularly chronic stress over time, it makes us sick. And if stress makes us sick, wouldn't it make sense that we would deliberately target and treat stress to try to prevent people from getting sick, as well as an adjunct to treating people's illness that has resulted from their stress? So that's pathway number 2. And again, I'm not going to spend a lot of time on that today because we're going to spend a lot more time on that later in the semester, but I do want to give you one study example so you get a feel for this. So in this particular study, they took a bunch of patients who said that their stress level was really high, and they do the random assignment. So everybody's getting their health care as usual, but half of this group is assigned to a control, they're getting nothing special. The other half is assigned to a stress management group where they got biofeedback and other stress management techniques in their group. And what they did, the outcome variable was they followed these two groups up one year later, and they looked at how many times they accessed healthcare in that particular year. And what they found is that those in the experimental group who got the stress management program, they decreased their medical office visits by 70% in that following year. They were accessing a lot less healthcare that next year because they were feeling better, because the stress management group helped their stress, helped them feel better. The control group, I want us to look at this difference here. The control group decreased their medical office visits by 26% that year. And I can tell you, if we ran a statistical analysis based on the insides of these two groups, anybody want to guess what the statistical analysis would be? Hopefully you have, but it would be a chi-square analysis, because chi-squares compare percentages as a function of the insides in each group in those percentages. And I can tell you, we can run a chi-square. That is a huge difference right there between 70 and 26%. Okay, so giving these people the stress management program was very effective in helping them feel better and reducing their medical office visits. But I want to take a moment, and this is a very important moment here, and I want to talk about what was going on down here. And I'm going to call this the placebo effect. Sometimes in industry, they call this the Rosenthal effect. But I want to talk about what is happening here. Keep in mind that all of these patients here have enrolled in the study. So there's a bit of like, they've invited me to enroll in this study. I've got a lot of stress. Let me do the right, let me be altruistic. Let me enroll in this study and help out the scientists here. So there's a little bit of altruism. Then there are research assistants in both of these different groups. These people had more of a therapist kind of giving the stress management program to them. These people had research assistants who were very kind to them. I love Ellen DeGeneres, and at the end of Ellen in her show, she has this phrase where she says, "Be kind to one another," and I love that. But this is very important for you future healthcare providers, that being kind and being warm and fuzzy and being empathic and being a good listener, all of that is the warm skills that we use in healthcare provision, and it is scientifically shown to be important, okay? Those communication, interpersonal skills, and that kindness is very important. These individuals here, so they've enrolled in the study, they go in, the research assistant reads a consent form to them, they may talk with them about the weather, like, how are you dealing with this rain? I really could use some sunshine, how about you? That type of thing. And it makes people feel good to feel like they're doing something, and then also just to be well treated by other people. So my guess right here is this is the placebo effect here. And the effect beyond 26% up to 70% is the therapeutic effect of the stress management program. Pathway number 3. Okay, so if we've talked about this, remember we talked about leading causes of death before the coronavirus, and we talked about how 65% of the risk for the top 2 leading causes of death was attributable to lifestyle. If behavior drives disease, wouldn't it make sense that we would have a whole pathway here that would be different types of behavior change to prevent people from getting sick, or behavior change after people got sick to help them get better? So I want to talk about Dean Ornish. Dean Ornish is a cardiologist, and he has done a bunch of different research studies. He's written books, that type of thing. Pretty famous. But Dean Ornish, in his own history, discloses that when he was in college, he got quite isolated, he got quite depressed, and he even became suicidal and had to drop out of college for a while and get treatment for his depression. So having said that, he's kind of like an owner of psychological services and an owner of behavioral services. And then he also talked about how when he was in, I think in his cardiology residency beyond med school, he went into cardiology, and he had a professor where, you know, they're there and they're reaming out a coronary artery in bypass surgery. And the professor was like, how did this get this way? And he made Ornish think about, okay, well, this plaque buildup is cholesterol and saturated fat. This person must have been eating a good bit of cholesterol and saturated fat. Other ways that this got there, okay, he must not be exercising, that his heart doesn't look very healthy, how else might he have gotten there? Well, maybe stress, you know. And he made him think back and back and back and back, and not just, let me teach you how to do this bypass surgery, but let me use this bypass surgery to get you critically thinking. How did this patient that we are treating right now, how did this patient get here? And basically, the lesson was this patient got here because of genetic risk and lots and lots and lots of either lifestyle behavior or lack of lifestyle behavior. Okay, so Ornish became a proponent of lifestyle behavior as a cardiac prevention program or a cardiac rehab program after a heart attack or after a stroke. So his cardiac rehab program, I'm going to use this term because he calls it rehab, whether it's for prevention somebody before a heart attack or afterwards, has diet. And his diet, he goes really, really low in dietary fat to the point where he encourages all of his patients to become totally vegetarian. He's got a supervised exercise program. All cardiac rehab programs, you go in and you exercise, and you've got nurses and a doctor on staff in case anything goes wrong medically. You've got people there that can intervene right away. And then an exercise physiologist writes a prescription, and then the prescription and the amount of exercise builds over time. There's a stress management component. In his particular program, he does a lot of different meditations and mindfulness stuff, and then he does getting people doing yoga. And then he also has them doing a support group where they meet and they talk about their stress and their families and their lives, and they support one another and learn how to manage their stress better. So this is the comprehensive program. In one study that was published in 2014, this rehab program cost these patients $10,000 a year to attend the program. Whereas if we take a look at the cost of coronary bypass surgery, which we refer to as bypass, they spread, reroute, that costs somewhere between $90,000 and $150,000 just for that surgical procedure. And so he's sort of saying, like, look, my program is much cheaper. The typical surgery is much more expensive. And he has shown that his lifestyle program reverses heart disease. So this would be an arterial flow, a nice, healthy arterial flow after his program. This would be an example of an artery that is really, really struggling to flow blood. So this is signs of definitely arterial cardiovascular disease down there. I want to pause for a second. I want to talk about us versus the Canadians, though. In the United States, if you've got blocked coronary arteries or blocked carotid artery and you are well insured and your cardiologist says you need this surgical procedure, it is customary in the US, if you're insured, to get that procedure very soon after that diagnosis, okay? In Canada, on the other hand, they are a socialized medicine country. They don't have insurance. Tax base goes and pays the healthcare providers. People go and they get their healthcare and they get it for free. In Canada, they ration the number of angioplasties and the number of coronary artery bypass surgeries, the bypass surgeries. They ration them. So if you're in Canada and you've got coronary blockages, carotid blockages, and your cardiologist diagnoses that, they will put you on a wait list. And on the wait list, they, say, okay, we think we can get you in for this surgical procedure in about 2 months. It'll be 3 months at the latest. So then the Canadians go, oh no. And then, like in South Park, their heads go like this. And then they get on the waiting list and then they go home, and a lot of them like, okay, wow, this is kind of scary. And then they start changing their lifestyle behavior and looking up things and learning how to change their eating and exercising more and practicing yoga for stress management. And you would think that because we've got these very different norms for how we deal with these people at risk in the US versus Canada, that Canadians would be dropping off like flies on the wait list. They're just dying and dying and dying on the wait list. And in the US, they're doing great because they're getting their surgeries. When we've studied the differences of people who are equally sick and getting very different timing and very different treatments, we find no differences in mortality between these Canadians at equal risk and the people in the US at equal risk. And so that speaks some things to us. It actually speaks to the fact that we are relying in the US much more frequently on these surgical procedures that are high expense. They're very expensive Band-Aids. They don't take care of the entire cardiovascular disease. But if you take a look at what Dean Ornish is doing, his program reverses heart disease. We're going to see later on in the semester when we do cardiovascular disease, the typical treatments that we do in the US without cardiac rehab, just the surgeries and the meds, you see a progression of coronary heart disease. But it's Dean Ornish's program that has shown a reversal of heart disease. So this is the kind of data that makes me kind of crazy, because it is not mainstream medicine to send everybody at risk for a heart attack or stroke into a preventative rehab program. It is also not 100% customary in our culture after a person has had a heart attack or a mild stroke that they've survived. We do not send everybody to a rehab program, despite the fact that the data says that is how we should be practicing mainstream medicine. And so it's not only driving up cost in the United States, there are times where I back up from this and I wonder, like, if we have the scientific evidence of what works better, is it even unethical if we are not prescribing that for everybody in that situation? So it's an interesting ethical dilemma. It's a financial dilemma because we've got a cheaper answer. For the patients, I used to supervise the mental health professionals in several counties in cardiac rehab. They get so much better. They come in, they're weak, they're hurting, they've been following an unhealthy lifestyle, and they get into those rehab programs and they make huge gains. I remember this one woman I worked with where she was up to walking a mile briskly, and she was so proud of herself for being able to walk a full mile briskly because she could barely take a few steps when she first started the program. So amazing progress these people make. Okay, next pathway, the social support pathway. And before we get into what's going on this slide, I want to back up a little bit. And we will spend more time on social support later on in the semester, but the backup is people in our culture who feel connected, loved, in a network, are so much healthier physically, psychologically than people who feel like they are isolated, they're not connected, they don't have someone to love, they don't feel loved themselves. And even those people are healthier than people who feel outright rejected. So they're isolated because they feel rejected. So we are interpersonal creatures. Having that social support in our lives is very important for us as human beings. Okay, one of the most common surgical procedures performed in the US is a C-section. C-section It's typically performed either, sometimes women are even asking for it nowadays. If baby's head is bigger than mama's pelvis, they'll schedule a C-section. But a lot of times what happens is mama's in normal attempting vaginal labor and delivery, and there's a complication. Baby's heart rate decreases, meaning the baby's in distress. If the baby poops in utero and there's this really sticky meconium, this black meconium that comes out of the amniotic fluid, that baby has pooped in utero because they're in distress. So they look for different signs. If baby's in distress, oftentimes obstetrician gets in there and they anesthetize her, and then they do a C-section. They open up the abdomen, they open up the uterus to take the baby out that way. It's called a cesarean section because apparently Julius Caesar's wife was one of the first women to ever undergo a medical procedure like that. So it's an expensive surgical procedure. It is risky to the mom. Her mom's recovery is going to be a lot harder if her abdomen has been cut open and her uterus has been cut open than a vaginal delivery. Now, there's recovery in a vaginal delivery, but let's just kind of put this into historical context. Women all throughout all of ancient history have been pushing babies out of their vaginal canal. And so it's, there's some discomfort there, but women heal. It's a pretty easy natural healing because women have been doing this forever. Okay. So in this particular study, what they did is they studied the value of a doula in a woman who is in labor and delivery. And keep in mind, a doula is not a midwife. A midwife is a master's level practitioner who can deliver babies and see women through her prenatal care. It's not an obstetrician who is a medical doctor who has training and this kind of stuff. A doula is normally a trained individual. They're usually women. They could be men, but customarily they tend to be women. They're oftentimes women who've had their own birth or their own babies. And the doula meets with the woman on a regular basis during her prenatal care and gets to know her. And then the doula attends the labor and delivery. So in this situation, you're seeing her, this woman she's rubbing her shoulders and her back. This doula is probably feeding her ice chips if she's thirsty. This doula, I had back labor during my second son's birth, and it sure would have been nice to have a doula just pushing on my lower back and counter pressuring that back labor. His head was up against my spinal cord, and so every time I would have a contraction, I would feel pain in my spinal cord. It's delightful. He was my Humpty Dumpty baby. He had this huge head. It was kind of hard to birth. Anyways, okay, so the doula she attends to the woman. She even, like, you do a certain kind of breathing early on in labor, and then you switch to a very different kind of, you do the soothing, slow breathing early on, and then there's a panting kind of breathing that ideally women are doing later in labor, and then when they're pushing in the contractions at that point in time. So this doula is just there. She might be managing partner and helping with partner, encouraging partner to do the right things or telling partner don't do that. She might be making phone calls and sending out information to family members. So she's like a nice valet for labor and delivery. So let's look at the research. So in this study, they took these women about to go into labor and they randomly assigned, everybody got their medical care the same. So it wasn't like the doula delivered the baby. I always find that fascinating because, look, let's give credit to who's doing the work here. It's the mom. It's the doctor or the midwife that catches the baby and delivers necessary medical care there. So 204 women. The experimental people, that's spelled wrong there. Sorry about that. The experimentals got the doula, the control group did not. And what they found was that having the doula there decreased the rate of requesting epidural anesthesia by 85%. And epidural, when you got to ask for that epidural early on because if you're real late in labor, you can't ask for it, they can't give it to you. It's weird, it's a little scary because they put this big old needle into your spinal cord and they put anesthesia into your spinal cord, but when it works really well, it just nicely, gently numbs you from the waist down. And I had a really effective epidural in one of my deliveries and a very non-effective epidural in my other delivery. But it was, in the first one, I just remember it was like I'd been up all night long. I was exhausted. I was doing my breathing. I was coping, but it was exhausting. And I remember after I got the epidural, it kind of numbed me. I could still feel contraction, but they didn't hurt nearly as much. Numbed me from the waist down, and it was just sort of like, whew, I could relax. And at that point, I was really close to being able to push with my firstborn. And it was just enjoyable. It's like, okay, I've got the energy here to push this baby out. And that was easy, that part. But it was just kind of nice to enjoy it. But up until that moment, I was spending so much of my energy just coping with the contractions. So the fact that these decreased by 85%, these women were nice and relaxed. They had the support that they needed from this doula and maybe a partner in the room. And they just didn't need the anesthesia. So congrats to them. It decreased the rate of labor by 2 hours. And the quicker labor can go, as long as you're in a safe setting, the better. Prolonged labor is very, very exhausting. If women have labored in the contractions, especially up to the point where now they're being asked to push, which is very labor intensive, some women just don't have it. They don't have the energy at that point in time. So decreasing labor by 2 hours, good. Here's the cost saving. It decreased the rate of needing a C-section by 56%. That is amazing. These women were a lot more likely to make it through their vaginal delivery than needing an emergency C-section. And this is where the money savings came in, because a vaginal delivery much cheaper than a C-section. It also decreased by 50% the number of babies needing to stay 48 plus hours. The babies that need to stay 48 plus hours have had complications, and the most common complications are problems with their breathing. Keep in mind, I want you to know that it is better for a baby's breathing when they go through the birth canal that has been contracting. It gets it helps get all the phlegm and stuff out of their lungs, and it gets their lungs working. And it's really, really a good thing when the baby first comes out and baby cries. It's not like they're like, hey, I'm distressed. It's sort of like, crying. They're working on getting their breathing going. When a baby is pulled out of a C-section, they haven't had, because they've been in the uterus, they haven't gone through the cervix and the birth canal where they've had those contractions. They have more difficulty stimulating and getting their breathing, and then they oftentimes have a lot more that they have to suction in babies born with a C-section. The doula at the time of the study cost $200. So just to add this nice person to come and cater, be the valet to the labor and delivery, cost only $200. I did not know about doulas back in the days when I was having babies. I wish I did. I would have loved to have had this experience. I think it would have been awesome. So really good. Win-win for mom, win-win for baby, win-win for cost savings here in this social support pathway. And keep in mind, this is only one intervention that we're talking about. And on that note, that is the end to part 2 of the intro lecture. So I am going to stop share and say goodbye now, everybody.